Welcome everyone here to the newly formed Certificate of Need Task Force. I want to thank all my fellow senators and representatives for being here and for their willingness to participate, to listen, and to evaluate the ideas that we bring forth during this task force time. I also want to thank those in the room as well for being here, and those who are in the auditory and the visual audience with us today. I hope that everybody will learn something today. And with that being said, Ms. Secretary, would you please call the roll?
Senator Berg, Senator Givens, Senator Meredith, present. Senator Schickel, present. Representative Burke,
present.
Representative Elliott, Representative Proctor,
present.
Representative Whitten,
Here.
Co-Chair Douglas,
Present.
Co-Chair Weber.
Here.
Okay, we do have a quorum, and so we can start this meeting. First of all, I'm going to introduce myself, and I'm going to ask the members of the committee to introduce themselves. I'm Senator Donald Douglas. I'm District 22 State Senator.
State Representative Russell Weber, co-chair of this committee, represent the 26th House District.
Susan Tyler Whitten, State Representative, District 31 in Louisville.
Mary Ann Proctor, State Representative, District 60 in Boone County.
John Schickel, I serve in the Senate. I'm excited to be on the committee. This is a topic that is that my constituents are very concerned about, so I'm here to learn and find out more about it. And I want to thank leadership for appointing me on the committee, and I also want to thank them for creating this committee because it is something that I think that is very much in need.
Daniel Elliott, I'm the state representative for the 54th District, Boyle and Casey counties, and I also serve as chairman of the House Judiciary Committee. So I'm not sure if I'm as excited as Senator Schickel, but I appreciate his sentiments, and thank you to leadership for the appointment.
Good morning. I'm State Senator Steve Meredith, representing the 5th District, which is Meade, Breckenridge, Grayson, Butler, and Ohio counties. And I have 40 years of healthcare experience. So that's why I'm not quite as excited as Senator Schickel is to deal with this topic, but I know it's one that needs some great examination. Look forward to the discussions. Thank you.
Good morning. I'm Lindsay Burke, State Representative for the 75th District in Lexington. Pleased to be here. Thank you.
Thank you so very much, members of the General Assembly. Our hope with this task force today and what we plan to do is review Kentucky's Certificate of Need program, including state health plans and all the related statutes. We also plan to review the need to maintain or modify Certificate of Need for each of the covered health services, and we will submit any findings and recommendations that we have regarding the Certificate of Need to the Legislative Research Commission for referral to the appropriate committees of jurisdiction. Now, ladies and gentlemen, we actually have two groups who will be presenting today, and I like to verbally say that each of these groups are aware of how much time they have to present. Since I expect everyone on our committee to participate and take notes, I will respectfully ask them to withhold their questions until the presenters have had time to present. But I also will respectfully ask our presenters that when they are asked a question, if they will hold answers to those questions to between 1.5 to 2 minutes. I want to do this because I want to make sure that everyone stays engaged in the information that's being presented. I also will respectfully ask that no acronyms be used. We often lose people in the audience, and we lose people who aren't even in the room if we use too many acronyms. So that would work well. Our first presenters couldn't be here in the room today, so they are on video. So if you would tell us who you are.
Sure. Thank you so much. My name is Samantha Scotti. I'm with the National Conference of State Legislatures. We apologize for not being there in person, but are very appreciative to be part of the discussion today. Thank you.
Thank you, Ms. Scotti. Would you please raise your right hand? Do you solemnly swear to tell the truth, the whole truth, and nothing but the truth?
Yes, I do.
Thank you. You may proceed with your presentation.
Wonderful. And I will share my screen now. And I believe you all have a copy of this presentation as well. Wonderful. So as I said, my name is Samantha Scotti. I'm a project manager with the National Conference of State Legislatures. And we're excited today to help provide background information and a national overview related to Certificate of Need as you all discuss the Certificate of Need program and what is best for Kentucky. So just a quick overview of what I will be covering today. I'll start with a very brief reminder of who NCSL is, and then provide some background and national overview related to Certificate of Need programs, then provide a deep dive into Certificate of Need by sharing some state examples, highlight recent Certificate of Need legislation, and then wrap up by referencing various research and studies related to Certificate of Need. And as a reminder, so NCSL is your national bipartisan membership organization, and we serve all 7,386 state legislators and over 20,000 legislative staff nationally. And it is our mission to strengthen the legislative institution. And we do this through a number of different vehicles like today's presentation. So listed here are just a few of the services that we provide to you all, state legislators as members of NCSL. And before I dive into my presentation, I did want to just note that any policy or state examples that I will reference today are purely informational and for informational purposes. And this does not indicate NCSL supports any of these one policies. So we are here not to provide recommendations, but rather share state examples and other information. So diving into Certificate of Need background and national overview. And what is Certificate of Need? And I know some of you all might be familiar with this, but again, we're here to provide some baseline and background information. So as a reminder, Certificate of Need laws require healthcare facilities to seek state approval prior to major capital expenditures or new projects. So this could include a nursing home expanding their bed capacity, or a health system opening a new ambulatory care center, or initiating new services like a burn unit. And a state health planning agency like a state Department of Health or another entity then reviews the proposed project and determines whether or not there's a need for it based on a host of different factors or criteria. And these could include the effects of a new project on healthcare costs or what kind of services are currently available in a given area. So as you all know, Certificate of Need is a debated topic, and proponents argue that it can bolster access and control costs, and opponents argue that these programs have the opposite effect on access and costs. So proponents contending that Certificate of Need laws ensure services are not concentrated in more affluent areas, and many states require facilities to provide certain services to indigent patients as a condition of Certificate of Need approval. Opponents, however, argue that Certificate of Need laws may protect incumbent providers and could be overly burdensome in the approval process, and so may delay or inhibit service expansion in underserved communities. And a quick reference to some of the history around Certificate of Need. So the 1975 Federal National Health Planning and Resource Development Act required all 50 states to have structures involving the submission of proposals and obtaining approval from state health planning agencies before any major capital projects occurred. So this federal legislation withheld funds from states who did not enact Certificate of Need programs. So by 1978, 30 states enacted Certificate of Need programs, with the federal program then being repealed in the late 80s in 1987, alongside associated federal funding. And after that, 12 states discontinued their Certificate of Need programs. So that brings us today, with 35 states and DC currently having Certificate of Need laws in place, with a wide variation in the types of facilities and activities required for Certificate of Need approval. So for example, many states regulate a handful of licensed facilities like hospitals, nursing homes, outpatient clinics, or other facilities, and other states narrowly apply Certificate of Need to certain facilities like long-term care facilities. So those states including Ohio, Montana, South Carolina, and Florida. 3 states, as indicated here in orange, Arizona, Minnesota, and Wisconsin do not officially operate certificate of need programs, but they do maintain approval processes that operate somewhat similarly to certificate of need oversight. And I will touch on these variations later today in my presentation. One quick important note that even in states without certificate of need, there likely are still accrediting bodies or licensing agencies that do regulate healthcare facilities and ensure that facilities meet certain criteria as conditions for licensure, like staffing ratios or other quality metrics. So quick reference to some key terms related to certificate of need. And we know that this topic can be a bit jargony, and there are a lot of associated terms when discussing these programs. So to ensure that we're all on the same page, I've included some conditions or some common terms that might be included as you're discussing this topic. And so a lot of these definitions here on the slide are taken directly from state statutes, with exact definitions varying by state, of course. So to quickly run through these, as I know you will have them all as you continue your discussion, the oversight entity is the State Department of Health or other related entity that operates the Certificate of Need program and conducts the Certificate of Need review process. The regulated facility refers to the real property or equipment owned by a healthcare institution which the Certificate of Need program is applied to. Regulated services just mean the clinically related services provided through healthcare facilities. Capital expenditure is an expenditure made by or on behalf of the health facility that is not chargeable as an expense of operation or maintenance. Licensed bed or bed capacity is the total number of inpatient beds in a facility licensed by their respective state agency. And review cycle refers to the time frame set for review and initial decision on the Certificate of Need application. And service area is the current or projected service area to which the facility is or will be providing services. And now to provide a deeper dive into state Certificate of Need programs by highlighting a handful of state examples. And keeping those first three terms in mind from my previous slide, oversight entity, regulated facility, and service, we're going to dive into state programs, and I'm going to reference who the oversight entity and which facilities and services are regulated for each of these states. And then I'll also provide some details into Certificate of Need process and what the review process looks like in each of these states. So starting with Tennessee, the Certificate of Need process lives within the Tennessee Department of Health. So specifically, the Health Services Development Agency reviews Certificate of Need applications, and the Division of Health Planning sets the standards and requirements for demonstrating Certificate of Need. Tennessee regulates a combined total of 26 facilities and activities, and you'll see an example of some of those facilities and activities listed here. Other regulated facilities include initiating neonatal intensive care units or opioid addiction treatment provided through non-residential settings. So Tennessee outlines a detailed 13-step process for the Certificate of Need application and review process. And this includes steps like filing a letter of intent between the 1st and 15th of a month, a presentation from the applicant to the review entity, supporting opposition testimony, so supporting or opposition testimony, and the commission voting process. Additionally, Tennessee provides information on the Certificate of Need criteria that is then considered for the different facilities and through the application process. So for example, for freestanding emergency departments in Tennessee, determination is based upon existing access to emergency services within the proposed area and whether limited access is currently an issue. When determining need for hospice services, the criteria in Tennessee is based on a hospice need formula. And this formula looks at the average number of patients in a service area, annual deaths over the past 2 years. Pivoting to Virginia. So Virginia's oversight entity is the Division of Certificate of Public Need, which is in Virginia's Department of Health under the Office of Licensure and Certification. In total, Virginia regulates at least 30 combined facilities and activities. And you'll see, again, examples of those activities and facilities listed here, with other services, including converting beds in a facility to rehabilitation or psychiatric beds. Virginia's Division of Certificate of Public Need also uses certain criteria to determine whether a public need exists. And this includes the relationship of the project to the long-term health care state plan, which is established by Virginia, the need for advanced facilities to serve the population in an area, and the extent to which the project is accessible for all residents in the proposed area, and the immediate impact, economic impact, and financial feasibility of the project. And then finally, pivoting to Ohio. So the Ohio Certificate of Need Oversight entity is also within their Department of Health, specifically the Office of Health Assurance and Licensure in the Healthcare Services section. And the Director of Health in Ohio leads the review and grant Certificate of Need. So Ohio Certificate of Need program only applies to long-term care facilities as defined in statute. So you'll see here 2 bullets related to how they define long-term care facilities and statutes. And Ohio regulates 7 different activities related to long-term care facilities, as seen here. So Ohio has a number of considerations and criteria for their Certificate of Need review process, which includes the impact of the activity on the costs of long-term care services in relevant services areas, quality of services to be provided, and the impact of the reviewable activity on the availability and access of the proposed activities in that application. So the Certificate of Need application in Ohio must include a timetable for the project, identified project sites, and a plan for implementing the project on a timely basis. So pivoting to those 3 states I referenced during the beginning of my presentation that operate a variation on a Certificate of Need program. So we have Arizona, Minnesota, and Wisconsin here. So they don't, again, officially maintain what is considered a Certificate of Need programs, but they do have similar functions in the state. So Arizona maintains a program that they have termed Certificate of Necessity, and it aims to regulate just ground ambulance services in the state. So the application for the Certificate of Necessity program, these applications are submitted to the Arizona Department of Health, specifically the Bureau of Emergency Medical Services and Trauma. And then the department specifies criteria for the application and for the ground ambulance service providers, like the geographic service area, the level of services to be provided, so advanced life support or basic life support, hours of operation, and response time. The next 2 states that operate a variation on Certificate of Need are Minnesota and Wisconsin. And these states are unique because they each maintain a moratorium that prohibits the establishment of new facility licenses or new facility beds in certain settings like hospitals. Both states do have a process that then allows for an exemption from this moratorium. So in Minnesota, for example, the exception process is outlined in Minnesota statute, and it is termed a public interest review process to exempt from this moratorium. And the legislature actually retains the decision to grant this exception in Minnesota. Now pivoting to recent Certificate of Need legislation. So we have seen a good deal of introduced and enacted Certificate of Need legislation in recent sessions. So in 2023 alone, we've seen 5 states enact legislation modifying their Certificate of Need laws in some capacity. These are North Carolina, South Carolina, Virginia, West Virginia, and Washington. So now to just highlight a couple of recent Certificate of Need legislative examples. And when looking at some of these sorts of legislation enacted related to Certificate of Need, we can categorize state actions into 3 major buckets seen here. So substantial reforms, targeted modifications, and establishing additional Certificate of Need requirements. And I've included examples related to each of these buckets. So starting with major reforms. So Florida, Montana, and South Carolina recently enacted legislation limiting Certificate of Need oversight to long-term care facilities, and so essentially exempting hospitals and other healthcare facilities from Certificate of Need processes. So most recently, in just May of this year, South Carolina enacted legislation that eliminates Certificate of Need, except in the case of nursing homes, and the state had previously regulated facilities including hospitals and hospice care. So those are no longer subject to Certificate of Need review. So many other states make targeted changes and reform their Certificate of Need programs, such as exempting certain facilities or activities from approval. So for example, as seen here, Washington enacted legislation exempting rural health clinics in areas with home health shortages from Certificate of Need oversight. Lastly, some states have enacted legislation to bolster Certificate of Need oversight in certain areas. So both Illinois and Nevada enacted legislation requiring health facilities to seek CON approval prior to closing a facility. And just to note, we did track a handful of bills during the pandemic where we saw some states that operated certificate of need programs pause their programs during the pandemic, but those were all temporary. So now looking at certificate of need task forces and corresponding products. So a handful of states have, similarly to your group here, convened task forces or study committees to examine certificate of need in their state, all initiated via legislation. So in Georgia, just this year, Georgia established the Senate Study Committee on Certificate of Need Reform with the goal of looking at the effect of certificate of need on access to healthcare costs and specifically how CON affects rural areas. So the committee, which consists both of legislators and citizens representing health systems, physicians, and insurers, will publish findings and recommendations. Again, that was just established this year, so that report will be forthcoming. Connecticut established a task force consisting of 5 work groups with the goal of studying and recommending effects of certificate of need, and specifically in response to 10 matters. And just a couple of examples of what those 10 matters the task force was looking at. One was setting standards to measure quality due to consolidation in healthcare systems, and enacting higher penalties for noncompliance and increasing the staff need for enforcement related to certificate of need. So this is the only task force so far that we are aware of that has actually published recommendations, and this was very recently. Connecticut did publish their recommendations, and it is important to note that these are very Connecticut specific. So they included a lot of matters that were very, very unique to Connecticut. But for example, one of the recommendations related in that report was expanding the certificate of need process to allow the oversight entity to consider service quality based on generally accepted, nationally recognized clinical best practices and guidelines for healthcare quality. And then finally, South Carolina, as I just mentioned, just this year, they enacted legislation limiting certificate of need to nursing homes, but that legislation also included a component related to examining the effects of certificate of need repeal on healthcare quality and access in rural areas. So again, this is very recent, so the group has not produced anything, but it will present its findings to the General Assembly recommending any actions on rural healthcare access. Finally, we have been asked to reference any relevant research and studies related to certificate of need. And we know that there are a handful of studies attempting to answer different questions regarding certificate of need, like what are the effects on costs or quality of care? So these studies that are out there tend to be dense, and the methodologies look very different across the studies. And so I'm providing a snapshot of a couple of studies published from various journals. And we know that there are more studies out there. And so I'm not an expert in examining research methodologies, so I'm not going to summarize all of the outcomes and nuances of these summaries verbally here in my presentation. But generally, the takeaway is that evidence related to certificate of need is somewhat mixed. And some certificate of need researchers, specifically the team conducting the meta-analysis, which is the first study referenced here in the first column, found that literature has not reached a definitive conclusion on how certificate of need laws affect health expenditures, outcomes, and access to care. And referencing that they have suggested that more research is needed. So I'd also like to note just some important considerations when examining the research related to certificate of need. So comparing 2 state certificate of need programs is kind of like comparing apples to oranges, just because some programs regulate 26 healthcare facility types or activities, and some may regulate just one facility type. Also, when looking at cost and quality in these research studies, that can be a hard thing to measure. So looking at the association between certificate of need and healthcare costs. Healthcare costs in a community are driven by a number of factors like healthcare status, for example, prevalence of chronic disease in that community, average age or in that community, or the prices charged by the hospitals or other healthcare providers in that community. So considering all those factors related to healthcare costs, it can be difficult to assert causation related to certificate of need costs. as opposed to correlation. And then looking at healthcare quality, there are a number of measurable metrics used to examine healthcare quality, and these studies referenced here might just touch on one or a handful of different healthcare quality metrics, like hospital readmissions, prevalence of facility-acquired infections, just to name two common quality metrics related to healthcare. So this is why it might be hard to compare or generalize certificate of need programs and studies and analyze these programs across states or even within a state. So I'm happy to follow up with more information related to studies that we have found that exist in the realm of certificate of need. And then finally, just highlighting a handful of additional resources that NCSL maintains on certificate of need, including our certificate of need webpage, which further breaks down statutes related to certificate of need in all 50 states, including all the activities and services regulated in each of those states. Our healthcare cost coverage and delivery database, where we track any newly enacted legislation related to this, and then a recent magazine article that we wrote highlighting some trends related to certificate of need. And of course, please reach out anytime, and I will turn it back to the chair. And thank you again so much for inviting us to be part of this discussion.
Thank you, Ms. Scotti. I really appreciate the information that you've given us here today. When I mentioned questions after the presenter, I meant after each individual presenter. So I would like to open up to the committee if any committee members have any questions they would like to bring forth this morning. Co-chair.
Ms. Scotti, I have a question for you. Did West Virginia modify their certificate of need program in 2023?
Yes, they are one of the states that I referenced recently enacting legislation. That is correct.
Do you know what did they modify?
That is a great question. Let me look
And I
at
know
my
the answer to it, so I'll just go ahead and I'm just they exempted birthing centers from their certificate of need program, and I just wanted to illustrate that as an example to this committee of some changes that are being made by states across the nation. Thank you.
Thank you for highlighting that example. So a lot of the modifications that we have seen, I think, in those 5 states are likely around exempting a certain type of facility. I'm fairly certain that none of those have added new facility types.
Senator Berg.
Thank you for a very interesting presentation. How many states have, like my understanding here in Kentucky, that we had a real problem with ambulance services? And it looks to me like most of the states you're talking about don't even cover that under their CON. How many states cover that many facilities that were going down that low in the hierarchy of what needs to be evaluated, if that makes sense?
So I'm not sure if I'm following your question. Are you curious how many include EMS or ambulance services, or maybe, what is kind of the average number of facility types in each state?
Both.
So great question. And I will not give you a definitive answer just off the top of my head, because I don't want to misquote the number. We do on our webpage include all the facilities and activities included in each state, in those states, the 35 states in DC that have certificate of need programs. I'm not sure if I could say an average, but I would be happy to pull that number and send it to you after my presentation.
Thank you.
You could more easily look at how many activities and services are regulated per state.
Thank you.
Thank you so much for being here. I had a question. As far as the recent legislation, have you seen like geofencing being a part of what some of these states are changing with their certificate of need?
That's a great question. To my knowledge, a lot of those considerations are typically left to the regulating or the oversight entity. I'm not sure if the legislation is getting into that level of detail, but I can confirm or I can follow up on that to figure out how exactly that is addressed either in legislation or through the oversight entity.
Okay, thank you.
Thank you. I've got a question. Do you know how many states suspended their certificate of need during the pandemic, and was Kentucky one of them? And if we know the answer to that, when were those regulations brought back and why?
Sure, that is another good question, and I'm not sure for Kentucky for that specific timetable. I don't want to misquote the date, so I can also follow up on that. And but I know that you all are hearing from Kentucky agency after this, so they might be aware of that specifics. And if not, I'm happy to follow up.
Thank you very much. I do have a couple of questions I'd like to bring out here, or at least a couple of themes that I heard. It seems to me there was a common theme regarding concerns about rural healthcare access. Could you expand on that, or did your presentation give you any information in that area?
Sure. So what I have seen related is just a unique discussion around certificate of need in rural areas. So just mainly states acknowledging that services in rural areas, access to services in rural areas these access issues are unique for rural areas. So typically looking at different considerations when applying certificate of need to rural areas. That's what I would say states have mainly been considering.
I guess my question, more clarified, is did it talk about how the certificate of need affected the access, the presence or the absence of the certificate of need affected the access to rural health care?
Mm-hmm. So I do know that those task forces and study committees, both South Carolina and Georgia, are looking more into that. I'm not sure if any state has issued conclusive findings on how certificate of need affects rural healthcare access, but I do know that that is something states are trying to figure out. But I'm not aware of any study that specifically has come to a conclusion around certificate of need in rural areas. If does that answer your question?
It does. It does. That's exactly what I was looking for. And thank you very much. Anything else from the committee? Well, with that being said, Ms. Scotti, thank you very much for your presentation, and thank you very much for your time.
Of course. Thank you so much for the invitation. And I do know I have a couple of questions here to follow up on, so I will coordinate with LRC staff to get you all these answers. And thank you again so much.
Now, we do have our second set of presenters, and they are in the room. So I would ask them to step up to the table, make sure that your little green lights are on so that we can hear your lovely voices, and we will proceed. Introduce yourselves to the committee and those in the audience, please.
Sure. Well, thank you all for having us. My name's Adam Mather. I'm the Inspector General for the Cabinet for Health and Family Services.
I'm Kara Daniel. I'm the Deputy Inspector General.
Thank you very much. Would you both raise your right hands, please? Do you solemnly swear to tell the truth, the whole truth, and nothing but the truth?
I do.
Thank you very much. Proceed.
All right. So the CON, a little brief overview, the CON program is a state regulatory tool, controls a number of healthcare facilities in an area.
With all due respect,
yes.
Again, I would prefer to hear a certificate of need. Again, we know what we're talking about in this room primarily, and I apologize for having to interrupt you, but I do want to make sure that those in the audience are able to understand.
I'm sorry, certificate of need, yeah. Please stop me if I'm so used to using acronyms. So
I understand.
I do apologize.
Thank you very much.
Yes, I do apologize. Our state certificate of need law addresses several areas. One is type of healthcare facilities that require a certificate of need, certain activities that trigger the the certificate of need review, and the agency that reviews the applications is the Office of Inspector General, and then the information that we need during a certificate of need review to be deemed as complete. All right. A brief overview of the certificate of need program in the state of Kentucky. This was originally adopted in 1980 through the revised statute, Kentucky Revised Statute 216B.010, and the goal was to help with cost containment, improve quality, and increase access. The General Assembly finds that the licensure of health facilities and services is a means to ensure safe and efficient medical care. The proliferation of unnecessary health care facilities, health services, and equipment results in duplicity of cost and underuse, and proliferation increases the cost of quality health care. And then the Kentucky Revised Statute Chapter 216B authorizes the Cabinet for Health and Family Services to perform any need function or other statutory functions necessary to those three charges, which are improve quality, increase access, and create cost-efficient care. And then the KRS 216B requires certain types of healthcare facilities to obtain a certificate of need. Approval from the Cabinet for Health and Family Services before applying for licensure to operate a healthcare facility or service. The process by which potential healthcare providers can obtain a certificate of need is governed by both statute and regulation. And so KRS Chapter 216B requires certain types of healthcare facilities to seek a CON in order to apply for licensure to provide services. It also allows for the process by which affected parties can request a hearing. It establishes non-substantive review, prohibits transfer of certificate of need, and requires notice of change of ownership or modification on entities that require a certificate of need. The regulations associated with certificate of need, 900 KR 5020 incorporates the state health plan. This is updated annually and provides needs calculations and criteria and exemptions under which the the certificate of need program operates. And then 900 KAR 6010 through 6130. And that establishes review procedures, application procedures, fees, required notices, procedures for deeming an application complete, and batching cycles. The certificate of need review criteria rest under 5 criteria. The first is consistency with the state health plan, that it matches the services and criteria per the state health plan. The second is need and accessibility. It meets the needs based on an annual assessment of need through formulas showing a need in a geographical area for that service. Interrelationships and linkages appropriately complements the existing current healthcare providers in the area to give comprehensive, efficient care. Cost of economic feasibility and resource availability. It must be an economical and effective use when compared to alternatives, and will be able to have sustained operations. And then finally, quality of care. Must be able to meet the appropriate standards of care. All right, and I'll walk you through kind of, we created this, I think, for another committee hearing, but we'll walk you through as best we can. Please, this would be a good time to ask questions around the flow of the how certificate of need certificate of need operates. So it originally starts with the application that's incorporated by reference 900 KR 6065 and filed before the batching cycle deadline. The OIG reviews the application and will share with that entity that the application is deemed complete. If it's complete, then the application is subject to formal review or non-substantive review. If we find that it's not complete, we will ask the applicant to submit revisions or additional information in order to deem it complete. And then, so I'll go through the formal review process first for you, and then we'll go through the non-substantive process for you as well. And so the applicant, if it's a formal review, which is defined by KRS 216B 012 and set forth in 900 KR 6070, the Cabinet gives notice via a newsletter. Notice includes an affected party right to request a hearing. If no hearing is requested, then the administrative hearings officer issues a final decision. If a hearing is requested by an affected party within 15 days after the public notice, In accordance with case law, applicants bear the burden of showing the proposal meets the review criteria. And then an administrative hearing officer issues a final decision based on that. If the applicant qualifies for non-substantive review, then there is, if there's no hearing requested, then OIG issues a final decision. And I apologize, this is kind of in my way here. Let's see if we can get this. There we go. If there is a hearing requested by affected party within 10 days after public notice, then there is a hearing held, and the presumption of need is already in place unless rebutted by clear and convincing evidence by the affected party. And then, like in the formal review, the administrative hearing officer makes a final decision on that as well. And then the next...
With that being the case, could you give me an example of who might challenge?
Sure. So let me think of an easy... let's say if there is a hospital in a certain area providing MRI services, let's say, for example, they're meeting the need for... Well, it's not a non-sub. Let me think of a non-sub challenge. Or does it matter if it's formal or informal review? Okay. I'll just try and give you a hypothetical here, and it may not correlate completely. But if they're already providing enough MRI services, so another person applies for MRI services within that catchment area, they would go and be the affected party to say, we're already meeting the need of the community. Therefore, there shouldn't be another MRI service.
If I may ask one more question.
Sure.
Who determines whether that is in fact accurate or not accurate?
The hearing officer would have to do that through the hearing process.
So the hearing officer has that responsibility.
Correct.
Okay. Thank you.
I'll go over formal and non-substantive review for you all to give you a more clear picture on that. So formal review is the most common and most complex of the certificate of need application, of the two certificate of need application processes. This is where the applicant bears the burden of showing the proposed health service meets all 5 criteria established by KRS 216B 040-2A, and that's including consistency with the state health plan. And then, as mentioned previously, the decision is made by a hearing officer, and that takes approximately 6 months. And then, here are some of the services or facilities that require a formal review. Ambulance services, we did, and I'll talk about this more. There were some changes made with House Bill 777 that changed that somewhat. Ambulatory surgical centers, chemical dependency programs are larger, obviously hospitals, hospice, long-term care facilities, organ transplant programs, and special care neonatal beds. And just to give you a definition of long-term care facilities, those include nursing facilities, personal care homes, intermediate care facilities, for individuals with intellectual or developmental disabilities.
Mr. Inspector General, I do.
Yes.
I'm breaking my own rule.
That's okay. You're allowed to do that, I think.
Yeah. They've given me this nice gavel,
Yes.
so that affords me a little bit of leeway. Who determines the hearing officer? Who the hearing officer is?
I think they're, Kara, you could.
So we have an administrative hearings office. OIG doesn't, but for the cabinet, and they handle all types of hearings. I am not aware if they specialize in CON or how they make those assignments, but it's determined within that office who is assigned the case.
I'm sorry, within the office of?
It used to be, there's been some reorganization, but it's the hearings branch is how we always referred to it. It is within the cabinet, but it is not with.
Office of the Ombudsman.
It isn't, yes, that's correct. But it is not within our office.
Thank you. I'm sorry. Proceed.
Absolutely. And then non-substantive review. These are services that are designated in statute or by regulation. There certainly can be an affected party, but that there is the need for the service is presumed, and so evidence to the contrary must be very clear and definitive in order to be denied. And this process is a much faster process to go through, an easier process. So the statutory authority for non-substantive review, these are the 5 circumstances with which the non-substantive review for CON application can be deemed. And then the last one is obviously other circumstances that the cabinet by administrative regulation may prescribe. And so the first is a change in location for a healthcare facility. The second, to replace or relocate a licensed health facility with no major substantial changes in both health services and or bed capacity. The third is to replace or repair worn equipment, and that there are some caveats to that. I think the equipment must be 5 years or older. And then obviously for cost escalations. And then the next slide, I'll kind of go over some of the regulatory criteria. So acute care providers seeking to transfer acute care beds to a new facility under common ownership in the same county. So if you have a hospital and you want to open another hospital within the same county, you can transfer some of those acute care beds within that same catchment area. And then converting existing beds, acute care beds, to psychiatric beds for adult patients. And that was established recently in our emergency reg. That was due to a need post-pandemic that we're seeing a lot of our psychiatric patients sitting in emergency departments, and they really need to be treated in their acute crisis. And so this is to help alleviate some of that, specifically in some of the rural areas. And then adult day health centers, House Bill 777, which I mentioned before, grants certain ambulance providers with non-substantive review status, and industrial ambulance providers, freestanding birthing centers, freestanding emergency departments owned by Kentucky licensed hospitals and located off campus, private duty nursing agencies, and program of all-inclusive care for the elderly. And that's, I know you don't want us to use acronyms, but people commonly know that as the PACE program. So, moving on to the next slide here. So here, the certificate of need exemptions authorized by state law. And I won't go through all of them, but you can see those here. Most of those are smaller entities with smaller capital investments. And then there are, as spoken about previously, House Bill 777 was pretty comprehensive, and that really worked on ground ambulance services. And so this exempts city-owned ambulance services that provide transport in a counterminous city outside of its service area if the city has an agreement. And then effective until July 2026, the hospital-owned ambulance services can provide a non-emergency or emergency transport originating from the hospital. So that could be inter-facility transports as well as non-emergency transports to a skilled nursing facility. And then as well with House Bill 77, there was a certificate of need exemption for cities or counties seeking to provide emergency ambulance transport services under the following conditions. And that was the city or county government had conducted a public hearing to demonstrate an imperative need to provide emergency transport within the city or county. And it would directly provide emergency transport within its jurisdiction boundaries, either into a contract or enter into a contract with hospital located within its jurisdiction or adjacent county if there is no hospital in that county. There is also a private practice exemption from certificate of need and licensure. So those practitioners that are providing the services themselves and are the owner of that facility, they qualify for either an exemption
Excuse me,
even if there is.
could you pull the microphone a little closer?
Yes, I'm sorry.
We're losing part
sorry.
of this information.
They qualify for an exemption even if it is in the state health plan. So there are exemptions within the state health plan for provider-owned entities that would normally go through either a non-substantive program or a formal review. And then that's through 900 KAR 6130, Section 3.1a establishes the requirement for practitioners to have overall responsibility for patient care. And so, for example, a physical therapist can own a facility and employ a practitioner outside of his or her scope, such as a speech therapist, and still qualify for the private practice exemption as long as the physical therapist maintains overall responsibility for directing, coordinating care and management of services. And then additional exemptions from certificate of need and licensure. In 2018, there was the passage of House Bill 444, which amended KRS 216B 020 and established an exemption from CON and health facility licensure for outpatient facilities that provide non-emergency, non-invasive services equivalent to the types of services provided in private office or clinic. And those include primary care centers, specialty health clinics, retail-based clinics, ambulatory care clinics treating just minor illnesses and injuries, and then outpatient rehab services, rural health clinics, and then networks and off-campus hospital-acquired physician practices. As hospitals have acquired primary care physician practices, those are considered exempt under House Bill 444. And currently pending regulations, we have the annual update with the state health plan. OIG has filed 900 KAR 5020 and 900 KAR 6075 on March 15, 2023. The proposed changes include the following. It allows acute care hospitals to convert the existing acute beds to psychiatric beds, as I mentioned earlier, and that would, for non-substantive review. It deletes outdated language referring to tuberculosis beds and allows a long-term care pediatric facility to add 50 or fewer beds. It also allows for acute care hospitals, a critical access hospital or nursing facility to provide home health services to their patients. And it makes megavoltage, radiation, MRI, and PET applications subject to non-substantive review. And it broadens what qualifies as the ophthalmological ambulatory surgical center. And we're currently working on the statement of consideration, and that should be out shortly for those changes within the state health plan. And then our emergency circumstances, we have a pending regulation out for that, and in an effort to help address situations which involve an ambulance provider that surrendered their license. We were working with Kentucky Board of Emergency Medical Services. Two providers notified them that they would be ceasing operations, and in order to continue operations within Knott and Lewis counties, we have changed our emergency circumstances to allow a provider to come in quickly and provide those services, so there is no lapse in services within those counties.
I do have a question on that note.
Sure.
Who is we?
I'm sorry, Office of Inspector General and the Kentucky Board of Emergency Medical Services.
Okay.
All right. And that concludes our presentation. We're happy to answer any questions for you.
Thank you very much. I know Senator Berg has a question.
Thank you, sir, and thank you. So this is a lot of information I'm trying to assimilate. Over the course of a year, average year, how many CON requests do we receive? How many CON requests do we say yes to? What percentage do we say no to? And why?
I will have to get you those answers. I don't have them. And I think it would vary. I think it might be easier to give you maybe 5 years pre-pandemic and then what we've got. So you can see maybe a 10-year run of it so you can kind of see what it looks like. But we're happy to get that information for the committee.
Thank you, because without those details, it's really hard for me to figure out, are we talking about building hospitals or are we talking about, opening up an outpatient dermatology clinic?
Sure. And then also there are changes within the state health plan that may modify those requests as well. So that's something to think about as well.
A follow-up question, sir?
Yes.
Actually,
go
I
ahead.
have several. So we started out at the beginning of the presentation, basically with an assumption, legislative findings and purposes, and purpose. And I don't think you'll know the answer to this, but I think we really need, as a committee, to think about this. Does the proliferation of medical services actually increase the cost of quality health care, which is an assumption that we made back in 1980? Or does competition decrease the cost of quality health care? And those are, I honestly think this is a presumption that we really need to evaluate and see, is it a correct presumption or not? Are we doing a service? I always thought CONs were basically to protect providers, not to protect patients. But that may be backwards in my head. I don't know. I am totally open to learning. But the basic assumption that the proliferation of services increases the cost of quality health care, which we made back in 1980, I think should be open to review. Thank you.
Senator Meredith.
Thanks, sir. I'm looking at your slide, legislative findings and purpose.
Mm-hmm.
Yeah.
And this is kind of a continuation of Senator Berg's discussion and comments. Originally adopted in July 1980. That was several lifetimes ago.
A while back.
And I think we have to acknowledge how different the healthcare delivery system was back in 1980. At that time, it was still predominantly cost-based reimbursement. And really, at least from a former provider standpoint, the intent of certificate of need was to control the expenses that were being passed on to Medicare and Medicaid because they were cost-based. There were no risk involved for providers for the most part. You buy a CT scanner, if it didn't have the number of procedures you thought it would, didn't matter. The cost is going to be picked up, at least at that time, 80 to 85% by Medicare and Medicaid. So really in 1980, the intent was to control the growth of Medicare and Medicaid expansions. And when I look at these particular bullets under here that the General Assembly finds, is a means to ensure safe, adequate, and efficient medical care. I don't think it's done that. The proliferation of unnecessary healthcare facilities, health services, in order to avoid costly duplication and underuse, don't think it's done that.
Man.
Proliferation increases of cost of quality of healthcare, I don't think it's done that. The final three bullets: improve the quality of healthcare, don't think it's done that. Increase access to healthcare facilities, certainly hadn't done that, particularly in rural areas, and we know we have some urban healthcare deserts, but lastly, to create a cost-effective healthcare delivery system. It certainly has not done that, and that's not a criticism of you folks, it's a criticism of the system. So the point I'm trying to make is, I don't think that the findings and purpose that we adopted in 1980 are appropriate for today. And Mr. Chair, what I would encourage is, I think we have to look more basic at this, is what is our intent for certificate of need. I think it has its place, I think it has some value, but I think we really need to do a real drill down on this in terms of what are we trying to accomplish. Certificate of need has historically been very prescriptive. We haven't done anything in terms of improving the access of care, which I think is a major deficiency on our part. You know, is it the intent of certificate of need to keep from the proliferation of services? Should the purpose of certificate of need, maybe we don't even need to call it that in the future, call it something else, is to ensure an adequate healthcare delivery system for all Kentuckians, just not for some. But again, if these findings and purpose is what we have from 1980, I don't think it is no longer adequate for the state of Kentucky, and presents some real obstacles to having the type of healthcare delivery system that we all want and need. So I don't know if that's a question as much as it was a sermon. I'm sorry for that. but I guess the basic question, do you really think that these findings and purposes are really appropriate for today's healthcare environment?
I think it's a very broad question and multifaceted, and I think this is certainly one facet, and I am not smart enough to know the right answer. I think, there's clearly 35 states doing 35 different things, and no one knows what the right answer is. Welcome and love for Kentucky to be the first to figure it out. I will put it that way.
Well, my apologies, Mr. Chair. We had a discussion at government contract review about asking people to speculate. I know I shouldn't do that. My apologies.
Thank you, Senator. Representative Weber.
Thank you, Mr. Chairman. I have several questions, and feel free to limit me if you choose. The first, I'd like to dovetail on a question or request and a comment from Senator Berg. On I believe it's slide 5 on certificate of need review criteria, you have the 5 points there. I would like for you to provide to this task force any certificate of needs that are rejected, how they are based on the 5 criteria. I'd like to see a breakdown of that. I think that would be helpful, and I think that would provide this task force with some additional information, and as soon as you can make that available to us, I certainly would appreciate that. On slide, I believe it's slide 10, statutory authority for non-substantive review. You have the 4th point there. It said for cost escalations. Can you give us a little more
Detail.
meaning to that, and also how is that determined?
Do you have that information?
Excuse me, I'm trying to find it. That is one of the factors laid out, or one of the categories laid out in statute. It has, I have not been involved in specifically in one of those, and that's the statutory language for cost escalations. If it's a cost escalation, it goes through non-sub review instead of the entire formal review process again. But that's what we've got for cost escalations. It doesn't start back at square one. It goes.
I think I could give you an example. If you're constructing something and you've given us a certain total capital expenditure, and you get into the project and you realize it's going to be double the cost, as many hospitals doing construction realize that, instead of going through the process all over again, you would just submit that cost increase to us.
Okay. Mr. Chairman, if I may.
Yeah, continue.
Let's go to the certificate of need application review flow chart. I do have a couple things related to this chart that I'd like to get some clarification on. So we have both formal and non-substantive review, and it talks about, or lists here affected parties may request a hearing within 15 days after public notice. Can you help us, first of all, define affected party, and who determines if we're going to proceed with a hearing where this is going to be reviewed and eventually be decided by an administrative hearing officer? Who determines if someone is an affected party to allow that hearing to proceed forward?
So, affected party is defined in 216B.015, I believe, and it is other entities that provide healthcare in that area or that propose to provide healthcare in that area. It can also be.
Excuse me, could you pull that microphone? Maybe it's just my hearing, but
Sure.
my hearing is pretty good.
It also includes people who receive healthcare in that area. But it's statutorily defined. And as you can imagine, that gets argued about a fair amount, but it would be the hearing officer in the same way that in a dispute before a court, the judge would make that decision about whether a party has standing. It's very similar. So the hearing officer would have to sort out whether the entity that is challenging is an affected party or not. There is an exception to that. I think we made a change for the PACE program, the all-inclusive care for the elderly. That affected party is a bit more narrowly defined, and so because it is very, very spelled out, our office can look at that initially, and if that person or whoever's or what entity trying to make that challenge does not fit within that more narrow definition, and it's very, very clear, then we could make that determination. But generally, it's the hearing.
And additionally, because we border so many states, no outside state that has a healthcare facility bordering our state that may service our population can be an affected party.
And regarding the chart, and this will be my final question, Mr. Chair.
You're fine.
Regarding the chart, so we have on the formal review, any decision, whether it's appealed or whether there's a hearing or there's no hearing, ends with the administrative hearing officer. On the non-substantive review, if there is a hearing, it ends with the administrative hearing officer making a final decision. If there's no hearing, then the OIG makes that determination. Can you explain to us the
we would
difference
just approve
there?
it because no one's opposed it. So
And the burden of proof in formal review, the party who is seeking approval has a burden to prove, but in non-sub review, it's presumed.
Okay.
They are presumed. Need is presumed, and they are presumed to have met the criteria. And an affected party who challenges that, they have the burden of proving that they did not meet those criteria.
Okay, thank you. I appreciate that.
And I'll also just add that the administrative hearing officer issues a decision, but they can then be appealed in circuit court.
Representative Proctor.
Thank you, Chair. Does certificate of need limit or regulate the size and scope of an existing entity or hospital system? So, for example, if you have a system that already falls underneath certificate of need, and there's a rapid increase in need of services, do they keep getting the ability? Does certificate of need limit their ability for expansion or no?
it does. Specifically around COVID-19, though, we offered exemptions, emergency exemptions that were temporary to accommodate for facilities or entities to be able to expand their services.
May I follow up? So if you have an entity, I guess what I'm asking, if when you have an area that's rapidly growing, independent of pandemic, there is a demonstrated need to have more services. Would another entity that wanted to come in be denied that, or would preference be given to the entity that already exists to expand?
There's no preferential treatment to already existing facilities.
Thank you. Thank you, Chair.
I'm going to follow up. I know, Representative Burke, you have something, but I'm going to follow up on that. I don't think there was any suggestion that there was preferential treatment given, but I'm not sure that we answered the question. The question was, how do you determine whether you have a pre-existing entity who is there, who will continue to operate, versus a new entity who is seeking to operate in that space? Is that? Thank you.
I think there would have to be need, either if it's non-substantive, there would have to be a presumed need in that community. If it was formal review, then it would have to, depending on the level of care, it would have to follow the criteria within the state health plan, and they would be able to show that they were able to provide those services. There was a need for those services to be provided, and that it's whoever were to file their certificate of need application. We don't really look at it as if you already have an existing facility there or not. It's just whoever files that application. Did that help answer that a little more clearly?
It did. Thank you.
Okay.
Thank you. Representative Burke.
Thank you, Mr. Chair. May I ask 2 questions?
Yes, proceed.
Thank you. My first question references slide 5, the 5 review criteria for certificate of need. And I'm thinking about the state health plan. My question is, who creates the state health plan, using what data, and do we audit that to ensure that we are constructing a good state health plan?
Sure. You want to talk about it's a long process, but we'll try and.
Right. So it's adopted through regulation. I can't speak to its original origins because it's been around a long time. The Office of Certificate of Need has been in different various places. It used to be much larger, used to have a much larger staff. So the document has evolved over time. We do, as far as like there are need calculations that are within the state health plan. We also conduct annual data surveys, and those are available, and those are relied on to see, how the numbers that were the services that were provided in each area by what facility in the prior year, and then just the process of adopting it each year. There is a statutory requirement for an annual update. We solicit comments from the provider community before we even draft the first version of the regulation each year. So it goes out in the CON newsletter. I think this last time it went out last fall, probably October. We give them a month and a half or so to submit suggestions for changes, and look at those within the office, talk to policy specialists, and make some decisions about what should go in the next version. And then it goes through the normal reg process at that point. And so then the draft is filed, and then there's another chance to comment on it. And we take all those comments, and that's where we are right now, is looking at the comments and trying to determine, should those changes be tweaked, should they stay?
And let me clear, it can be anyone can make a comment. So it's not just providers, it's associations, but it's individuals in the Commonwealth as well that are making comments.
Right, but the initial solicitation for comments, it goes out in our newsletter. Right.
Okay, so the initial data primarily or exclusively comes from providers, and then there's an opportunity for public comment. Am I correct?
Right.
Okay, thank you. My second question relates to the application flow chart in slide 6. And the question is this: what percentage of affected parties in the formal review or the non-substantive review are patients as opposed to healthcare providers? Okay. The reason I ask is if we're trying to maximize healthcare for patients, then I want to know how big is their voice. And if they have 15 days at max to respond, are we hearing them? So thank you.
Thank you very much. Senator Berg, did you have a question, ma'am? Okay, then I'll fill the space. Page 2, I have a concern. I see the word quality of care, or the words quality of care. Is there a process that you can help us with today, or that you know of, that really assesses what quality of care means. There are a couple of places where it says proliferation increases the cost and the quality of care. There are also, if we look under KRS chapter 216B, it says improved quality of healthcare facilities. I'm trying to find out, we use quality of care and quality of healthcare facilities, and I'm not sure that we have a way that is written or in statute or that I've been able to find that defines that. Could you help me with that?
Yeah, I don't know. Thank you. Center for Medicare and Medicaid Services obviously has several metrics that they work from. The state of Kentucky does not have a specific set of metrics where we are measuring those. We rely heavily on Centers for Medicare and Medicaid Services. I didn't say CMS. I'm really proud of myself. We rely heavily on their metrics as an evaluation for quality of care within the Commonwealth.
Thank you. I have a second question. Going back to the CON or the Certificate of Need application flow chart, if we move to the bottom under where it says hearing requests affected by party within 15 days, the darker box that says in accordance with case law. Could you help me out with that? I'm a physician. I'm not an attorney.
I will turn that over to our attorney.
Are you talking about the burden of proof issue?
Yes, ma'am.
Okay, right. So, yes, and what the Emergency Services CON Task Force asked about that last fall as well. So it is just traditionally the case that an applicant who is seeking a license or permission or any sort of government dispensation bears the burden of proving that they qualify for that. And that's consistent with most administrative hearings that are conducted by the state, which is why non-sub review spells it out differently. And it's just, although the statutes, the CON statutes don't specifically state that the party bears the burden of proof, that is through case law the way it is usually done. I looked at the CON cases that have been recorded, and that's how the courts have handled them. So, but the non-substantive review statute and also the regulation talks about it a little differently, and that's why that burden of proof is shifted in those types.
And I do have a final question, at least a final concern. Who selects the hearing officers, and how are those particular hearing officers selected to review a particular certificate of need application? Is there a round robin? Is there you just put a bunch of names in a hat and somebody closes their eyes and picks them out? So there are two questions there. I hope you could.
I can only answer probably a part of that. I do know there are lots and lots of different types of hearings that the cabinet is involved in, and a wide range of topics. So there's a separate office within the Office of Ombudsman, a separate division of hearing officers, and this is all they do. And they go through specialized administrative law judge training because they essentially act like judges. And I do not know, though, the piece about how they are assigned or if they specialize in the topics. That I don't know, but we can find that out for you.
Once you find out, could you deliver that information? If you send it to my office, then I can distribute it to the rest of the committee. There's no need to send all that paperwork out. We'll take care of some of those things. Are there any other? Senator Berg first. Sorry.
Thank you, sir. Your question actually sparked a question on my part. As far as quality of care, I'm traditionally a hospital-based physician, so Joint Commission. We have Joint Commission surveys. We participate them. We do well. God willing, we do well enough that we get, for 5 years, they don't have to come back. So that I'm very familiar, as chief of staff and as a hospital-based physician, what Joint Commission requires. For these outpatient facilities, is there a comparable evaluation?
It depends on the facility. Obviously, Office of Inspector General also surveys different facilities as well, and so I would say that is comparable. I know that that is the closest thing to an accrediting body such as Joint Commission. There are several other ones within the state of Kentucky.
So in follow-up, we do require outpatient surgical centers, outpatient pain care centers, outpatient birthing centers to meet some sort of ongoing quality assertion of some sort?
Yeah, there are also complaint surveys. If we get a complaint to our office, we go and evaluate them, and they have to meet all the criteria.
Okay, thank you. Thank you.
Senator Meredith?
Thank you, Mr. Chairman. This is kind of a procedural type of question. If an organization is granted a certificate of need and they start operation facility, but sometime down the road they decide they don't want to continue that service, do they retain that certificate of need, or who does the certificate of need belong to?
So when they start operating and they get a license, the certificate of need goes away. That's really kind of a placeholder for them to get the license under the provisions of the certificate of need. So if they're going to be a 100-bed acute care hospital, the certificate of need would say that, and then they would be licensed for that 100-bed acute care. And that certificate of need is no longer really a valid document anymore. Their license is what makes them valid. And then there can be a change of ownership to another entity, or within the process, there is the ability to move particular beds around within your catchment area as well. Did that help answer it? I know it's
kind of, sort of. Let me give you a hypothetical.
Okay.
And this goes back to the corporatization of medicine. If you're a hospital corporation and you own a certificate of need for a hospital, and you decide at some point in time that it's not getting the return on investment that you want, so you're going to close that hospital, they couldn't keep someone else from reopening that facility, could they?
no, somebody else could open another. Those beds are no longer with being utilized, so they would be able to. Someone else would be able to come in and.
So require another certificate of need application.
Yes, sir.
Okay.
Yes, sir.
Thank you. Thank you, Mr. Chair.
Proctor.
Just up to me. Thank you. Just one final question. So I'm looking at a recently granted certificate of need that establishes a 24-bed nursing facility, but this hospital has relocated them, and specifically out of my counties. What happens to them when they're relocated? Are those beds gone? Are they just closed?
I would have to look at the because we'll need to look at what the needs are within the county. If you can send me that, I'm happy to look at it and we can go through. It's a little dependent on a couple different factors. So it may change at the next survey cycle based on those. Like, did they move? They can move to a contiguous county, but they can't move, from Paducah to Pikeville, let's say. So I would need to look at the specific example to kind of help identify if there would be beds available in the next, or there may already be beds available within the county that are.
That kind of answered the question. So if they're relocating the beds out of my county, are those gone?
There may be, it's a nursing facility?
It's a hospital system that are relocating
Acute care beds or
nursing facility units, relocating them. Do they just shut down in the existing area? Do we lose those beds?
You would, yes. That to answer your question, yes.
Thank you. Thank you very much.
We have time for two more questions. One of those goes to Representative Burke.
Thank you, Mr. Chair. Referencing back to the presentation from NCSL, we were informed that Illinois and Nevada have legislation that requires health facilities to seek certificate of need approval to close services. And I think this dovetails with Representative Proctor's question. Do we require health facilities to seek a certificate of need if they're going to close a facility, or stop providing certain services in an area?
No, there's no certificate of need required for that. There is notification requirements.
There we are ending. We have one more. Representative Witten?
Thank you, Mr. Chair. When you talk about need, is it in statute for like a percentage of beds used or just beds? Is that in statute?
It's in the regulations.
In the regulations.
Yeah. If you look in the state health plan under each category of service, it will, sometimes it's formulas, sometimes it's not a formula. But if you look at it, and I probably should have brought you a copy, but if you look at the state health plan, it'll help explain that a little better.
Great.
Because it's multiple levels of care, right? You have to think about all the different levels. So some is ambulance services, right, which wouldn't require a...
Of course. Right.
Inspector, Deputy Inspector, I really want to thank you all for your patience this morning, and I'm impressed that you're both able to smile at the end of the grilling. The information has been very useful. What I would ask is those areas that we've asked for information, if you could get that to us as soon as you can, then we'd be grateful for that. I don't know, when's our next one? Just 1 second. Mm-hmm. I have my brains working for me, just as you do. For the members of the committee, we will be taking information for further topics that we can look at in the future. My co-chair will be chairing the next meeting on July 17. Again, I want to thank you, Mr. Inspector and Ms. Deputy Inspector for your time. Thank you very much. The meeting is now concluded. You're too kind.